14 Dyspepsia Jantak definition. Dyspepsia is derived from the Greek words delta upsilon dash, dys, and pisieta, peps, and literally means difficult digestion. In current medical terminology, dyspepsia refers to a heterogeneous group of symptoms in the upper abdomen. In the literature, dyspepsia is often broadly defined as pain or discomfort centered in the upper abdomen 1, 2 but may include multiple and varying symptoms such as epigastric pain, postprandial fullness, early satiation, anorexia, belching, nausea and vomiting, upper abdominal bloating, and even heartburn and regurgitation. Patients with dyspepsia commonly report several of these symptoms. 3 Several consensus definitions for dyspepsia and functional dyspepsia, FD, have been proposed, with the Rome Consensus Committees providing the most influential classifications. With time, definitions of dyspepsia have evolved to become more restrictive and focused on symptoms that are thought to arise from the gastroduodenal region, not the esophagus. 4. 5 Earlier definitions considered dyspepsia to comprise all upper abdominal and retrosternal sensations in effect, all symptoms considered to be referable to the proximal alimentary tract. 6 The Rome I and II Consensus Committees both defined dyspepsia as pain or discomfort centered in the upper abdomen. 2. 7 Discomfort includes postprandial fullness, upper abdominal bloating, early satiation, epigastric burning, belching, nausea, and vomiting. Heartburn may occur as part of the symptom constellation, but the Rome II committee decided that when heartburn is the predominant symptom, the patient should be considered to have GERD, not dyspepsia. The Rome III Consensus Committee, which defined dyspepsia as the presence of symptoms that are considered to originate from the gastroduodenal region, created a major restriction in the definition of dyspepsia, and this was confirmed by the Rome IV Consensus Committee. 4. 6 Only 4 symptoms, postprandial fullness, early satiation, and epigastric pain or epigastric burning, are now considered to be specifically of gastroduodenal origin, although many other symptoms are acknowledged as possibly coexisting. In patients with dyspepsia, additional clinical investigations may identify underlying organic disease that is likely to cause the symptoms. In these subjects, symptoms are attributable to an organic cause of dyspepsia, box 14.1, 812. However, in the majority of subjects with dyspeptic symptoms, no organic abnormality is identified by a routine clinical evaluation, including EGD, and these patients are said to have FD. The term uninvestigated dyspepsia refers to dyspeptic symptoms in persons in whom diagnostic investigations have not yet been performed and in whom a specific diagnosis that explains the dyspeptic symptoms has not been determined. Organic causes. The most prevalent identifiable causes underlying dyspeptic symptoms are PUD and GERD. Malignancies of the UGI tract and celiac disease are less common but clinically important organic causes of dyspeptic symptoms. 811, see box 14.1. The investigation of choice in case of dyspeptic symptoms is EGD, which allows identification of erosive esophagitis, Barrett esophagus, peptic ulcer, gastric or duodenal infections, and gastric or esophageal cancer. Systematic studies indicate that 20% to 25% of patients with dyspeptic symptoms in Western societies have erosive esophagitis, 20% are estimated to have endoscopy-negative reflux disease, 10% have peptic ulcer, 2% have Barrett esophagus, and 1% or less have malignancy. 9. 12 Minor endoscopic or histopathologic findings like duodenitis or gastritis do not seem to correlate with the presence or absence of dyspeptic symptoms. Intolerance to food or drugs. Contrary to popular beliefs, ingestion of specific foods, e.g., spices, coffee, or alcohol, or of excessive amounts of food has never convincingly been established as causing dyspepsia. 13. 14 Although ingestion of food often aggravates dyspeptic symptoms, the effect is probably related to the sensorimotor response to food rather than specific food intolerances or allergies. However, acute ingestion of capsaicin has been shown to induce dyspeptic symptoms in healthy persons and those with FD, with greater intensity in the latter group. 15 Dyspepsia is a common side effect of many drugs, including iron, antibiotics, narcotics, digitalis, estrogens, and oral contraceptives, theophylline, and levodopa. Medications may cause symptoms through direct gastric mucosal injury. Changes 177 box 141 Organic causes of dyspepsia: luminal GI tract, chronic gastric volvulus, chronic gastric or intestinal ischemia, food intolerance, gastric infections, CMV, fungus, tuberculosis, syphilis, gastric or esophageal neoplasms, gastroesophageal reflux, gastroparesis, diabetes mellitus, post-vagotomy, scleroderma, chronic intestinal pseudoobstruction, post-viral, idiopathic, IBS, infiltrative gastric disorders, Menetrier disease, Crohn disease, eosinophilic gastroenteritis, sarcoidosis, amyloidosis, parasites, Giardia lamblia, strongyloides stercoralis Rom, PUD medications, acarbose, aspirin, other NSAIDs, including COX-2 selective agents, colchicine digitalis preparations, estrogens, ethanol, glucocorticoids, iron, potassium chloride, levodopa, narcotics, niacin, gemfibrozil nitrates or listed, quinidine, sildenafil, theophylline, pancreatica, biliary disorders, biliary pain, cholelithiasis, cholecalcithiasis, SOD, chronic pancreatitis, pancreatic neoplasms, systemic conditions, adrenal insufficiency, diabetes mellitus, heart failure, hyperparathyroidism, intra-abdominal malignancy, myocardial ischemia, pregnancy, renal insufficiency, thyroid disease, and GI sensory-motor function, facilitation of gastroesophageal reflux, or idiosyncratic mechanisms. NSAIDs have received the most attention because of their potential to induce ulceration in the GI tract. Chronic use of aspirin and other NSAIDs may provoke dyspeptic symptoms in up to 20% of subjects, but the occurrence of dyspepsia correlates poorly with the presence of an ulcer. In controlled trials, dyspepsia developed in 4% to 8% of persons treated with NSAIDs, with an odds ratios ranging from 1.1 to 3.1 compared with placebo. The magnitude of this effect depends on the dose and type of NSAID. 0.16 compared with NSAIDs, COX-2 selective inhibitors are associated with a lower frequency of dyspepsia and peptic ulceration. See Chapter 119. 0.17 PUD is a well-established cause of dyspeptic symptoms and is an important consideration for clinicians in the management of these patients. However, the frequency of peptic ulcer in persons with dyspepsia is only 5% to 10%. 0.8, 9, 12 Increasing age, NSAID use, and HP infection are the main risk factors for peptic ulcer. See Chapter 53. GERD. Erosive esophagitis is a diagnostic marker for GERD, but most patients with symptoms that are attributable to reflux of stomach contents into the esophagus have no endoscopic signs of esophageal erosion but have so-called non-erosive GERD. Erosive esophagitis is found in approximately 20% of dyspeptic patients, and a similar number of patients may have non-erosive GERD. 0.8, 9, 12, 18 Empirical use of acid suppressive therapy decreases the likelihood of finding erosive esophagitis in persons with dyspepsia. See Chapter 46. Gastric and esophageal cancer. The risk of gastric or esophageal malignancy in patients with dyspeptic symptoms is estimated to be less than 1%. 0.11, 12 The risk of gastric cancer is increased among persons with HP infection, a family history of gastric malignancy, or a history of gastric surgery, or those who emigrated from areas endemic for gastric malignancy. The risk of esophageal cancer is increased in men, smokers, persons with high alcohol consumption, and those with long-standing heartburn. See Chapters 48 and 54. Biliary and pancreatic tract disorders. Despite the high prevalence of both dyspepsia and gallstones in adults, epidemiologic studies have confirmed that cholelithiasis is not associated with dyspepsia. Therefore, persons with dyspepsia should not be investigated routinely for cholelithiasis, and cholecystectomy in persons with cholelithiasis is not indicated for dyspepsia alone. The clinical presentation of biliary pain is easily distinguishable from that of dyspepsia. See Chapter 65. Pancreatic disease is less prevalent than cholelithiasis, but symptoms of acute or chronic pancreatitis or pancreatic cancer may initially be mistaken for dyspepsia. Pancreatic disorders are usually associated with more severe pain and are often accompanied by anorexia, rapid weight loss, or jaundice. See Chapters 58 to 60. Other GI or systemic disorders. Several GI disorders may cause dyspepsia-like symptoms: infectious, e.g., Giardia lamblia and Strongyloides stercoralis infections, tuberculosis, fungal infections, syphilis, inflammatory, celiac disease, Crohn's disease, sarcoidosis, lymphocytic gastritis, eosinophilic gastroenteritis, or infiltrative, lymphoma, amyloid, Menetrier disease, disorders of the UGI tract. Most of these disorders will be identifiable at EGD with mucosal biopsies. Persons with recurrent gastric volvulus and chronic mesenteric or gastric ischemia may also present with dyspeptic symptoms. See chapters 27, 30-32, 37, 107, 113, 115, and 118. The symptom pattern associated with gastroparesis, idiopathic, drug-induced, or secondary to a metabolic, systemic, or neurologic disorder, is similar to dyspepsia, as defined by older definitions. 17 The distinction between idiopathic gastroparesis and FD with delayed gastric emptying is a matter of ongoing debate. See later in Chapter 50. 18 Nausea and vomiting are cardinal symptoms in persons with gastroparesis and were not considered symptoms of dyspepsia by the Rome III and Rome IV consensus committees, thereby allowing the potential for symptom-based differentiation between dyspepsia and gastroparesis. 3.5. 18 Dyspepsia may be the presenting or accompanying symptom of acute myocardial ischemia, pregnancy, acute or chronic renal failure, thyroid dysfunction, adrenal insufficiency, and hyperparathyroidism. Functional dyspepsia. According to the Rome IV criteria, FD is defined as the presence of early satiation, postprandial fullness, epigastric pain, or epigastric burning in the absence of organic, systemic, or metabolic disease that is likely to explain the symptoms. Box 14.2.5 Dyspepsia symptom complex pattern and heterogeneity. The dyspepsia symptom complex is broader than the four cardinal symptoms that constitute the Rome IV definition and includes multiple symptoms such as epigastric pain, early satiation, fullness, epigastric burning, upper abdominal bloating, belching, loss of appetite, nausea, and vomiting. Although often chronic, symptoms in persons with FD are mostly intermittent, even during highly symptomatic episodes. 19 In persons with FD seen in a tertiary care center, the most frequent symptoms are postprandial fullness and bloating, followed by epigastric pain, early satiation. Box 142 Rome IV criteria for functional dyspepsia, postprandial distress syndrome, and epigastric pain syndrome. Diagnostic criteria *for 1 or more of the following: functional dyspepsia, bothersome postprandial fullness, bothersome early satiation, bothersome epigastric pain, bothersome epigastric burning, and no evidence of structural disease, including at EGD, that is likely to explain the symptoms. Diagnostic criteria *4 must include one or both of the following at least 3 days a week: postprandial distress 1. Bothersome postprandial fullness, i.e., severe enough to impact usual activities, syndrome, PDS, 2. Bothersome early satiation, i.e., severe enough to prevent finishing a regular-sized meal, no evidence of organic, systemic, or metabolic disease that is likely to explain the symptoms on routine investigations, including at EGD. Supportive criteria 1. Postprandial epigastric pain or burning, epigastric bloating, excessive belching, and nausea can also be present too. Vomiting warrants consideration of another disorder. Heartburn is not a symptom of dyspepsia but often may coexist with PDS symptoms that are relieved by evacuation of feces or gas. Should generally not be considered part of the dyspepsia symptom complex. Other individual digestive symptoms or groups of symptoms, e.g., from GERD or IBS, may coexist with PDS. Diagnostic criteria * must include one or both of the following symptoms at least 1 day a week. For epigastric pain: 1. Bothersome epigastric pain, i.e., severe enough to impact on usual activities, syndrome, EPS, 2. Bothersome epigastric burning, i.e., severe enough to impact usual activities, no evidence of organic, systemic, or metabolic disease that is likely to explain the symptoms on routine investigations, including at EGD. Supportive criteria: pain may be induced by ingestion of a meal, relieved by ingestion of a meal, or may occur while fasting. Postprandial epigastric bloating, belching, and nausea can also be present. Persistent vomiting likely suggests another disorder. Heartburn is not a symptom of dyspepsia but may often coexist with EPS. The pain does not fulfill criteria for biliary pain. Symptoms that are relieved by evacuation of feces or gas generally should not be considered part of the dyspepsia. Symptom complex. Other digestive symptoms, such as GERD and IBS, may coexist with EPS*. Criteria fulfilled for the previous 3 months with symptom onset at least 6 months prior to diagnosis must fulfill criteria for PDS and/or EPS. Nausea and belching. Point 3, 2023. There is considerable heterogeneity, however, as demonstrated, for example, in the number of symptoms that patients report, Fig 14.1. In the general population, the most frequent dyspeptic symptoms are postprandial fullness, early satiation, upper abdominal pain, and nausea. 24-26 Weight loss is traditionally considered an alarm symptom, pointing toward potentially serious organic disease. Studies in tertiary care patients with FD have also shown a high frequency of unexplained weight loss. 2021 and population-based studies in Australia and Europe have shown an association between uninvestigated dyspepsia and unexplained weight loss. 25, 26 Subgroups. The heterogeneity of the dyspepsia symptom complex is well accepted. Factor analysis of dyspepsia symptoms in the general population and in tertiary care patients with FD have not suggested that FD is a homogeneous, i.e., unidimensional, condition. 25-27 These studies have confirmed the heterogeneity of the dyspepsia symptom complex but have not provided a clinically meaningful classification of the syndrome. Fullness, bloating, pain, nausea, early belching, epigastric vomiting, satiety, burning. Fig 14.1 Frequency of symptoms, percent of patients, and their severity ratings in 674 patients with functional dyspepsia seen at a tertiary referral center. Unpublished, University of Gauss-Thuisberry, Leuven, Belgium. Several attempts have been made to identify clinically meaningful subgroups of persons with dyspepsia to simplify the intricate heterogeneity of the dyspepsia symptom complex and to guide management. The Rome II Consensus Committee proposed a subdivision based on a predominant symptom of pain or discomfort. 2 Although correlations were found between this classification and the presence or absence of HP infection, absence or presence of delayed gastric emptying, and response or lack of response to acid suppressive therapy. 28, 29 The classification has been criticized because of the difficulty in distinguishing pain from discomfort, lack of a widely accepted definition of predominant, uncertainty about overlap between the symptom subgroups, absence of an association with putative pathophysiologic mechanisms, and, especially, lack of stability of the predominant symptom over short time periods. 4, 30-33 The Rome III Consensus Committee proposed a different classification, Fig 14.2. Studies in patients with FD seen at a tertiary care center and persons with uninvestigated dyspepsia in the general population have revealed that between 40% and 75% of dyspeptic persons report aggravation of symptoms after ingestion of a meal. 26, 34, 35 Assuming that a distinction between meal-related and meal-unrelated symptoms might be pathophysiologically and clinically relevant, the Rome III Consensus Committee proposed that FD be considered an umbrella term and that the postprandial distress syndrome, PDS, characterized by meal-related dyspeptic symptoms, postprandial fullness, and early satiation be distinguished from the epigastric pain syndrome, EPS, characterized by meal-unrelated dyspeptic symptoms, epigastric pain, and epigastric burning. 4 In population-based studies, the Rome III-based classification of FD into EPS and PDS showed the existence of both entities, with little overlap between them. 36-38 By contrast, studies of persons with FD who sought consultation with a physician have shown major overlap in Rome III-defined PDS and EPS. 1, 39, 40 The Rome IV Consensus Committee aimed to reduce this overlap by considering all postprandially occurring symptoms to be part of the PDS. 5 Therefore, when epigastric pain occurs postprandially in patients with early satiation or postprandial fullness, the patient is still categorized as having the PDS, see Fig 14.2. Epidemiologic studies and studies in patient cohorts have shown that the PDS is the dominant subgroup and that overlap with the EPS is small with the Rome 4 classification. 5, 41, 42 overlap with heartburn and IBS. The issue of overlap between dyspepsia and GERD has been a challenging one. Although earlier investigators considered a group of patients with reflux-like dyspepsia 6, the Rome consensus committees did not consider heartburn to arise primarily from the gastroduodenal region, and this symptom was excluded from the definition of dyspepsia. 2, 4, 5, 7 Heartburn commonly coexists with dyspepsia, however, in both the general population and patients with FD. 18, 26, 29, 43 Moreover, distinguishing GERD from dyspepsia is hampered by a number of confounding factors, such as the presence of dyspepsia-type symptoms in many patients with GERD. 18, 26, 44, and difficulties in recognizing heartburn by patients and physicians. 18, 45, 46 The Rome 2 Consensus Committee stated that patients with typical heartburn as a dominant complaint almost invariably have GERD and should be distinguished from patients with dyspepsia. 2 Although this distinction is valid. 32, 47, 48 The Rome 3 Consensus Committee proposed identifying patients with frequent heartburn and using a word picture questionnaire to identify patients with FD who will respond to acid suppressive therapy or in whom pathologic esophageal acid exposure can be demonstrated. 47, 48 The Rome 3 and 4 Consensus Committees state that heartburn is not a gastroduodenal symptom, although it often occurs in association with symptoms of FD, and its presence does not exclude a diagnosis of FD. 4, 5 Similarly, the frequent CO occurrence of FD and IBS. 49 is explicitly recognized in the Rome 3 and 4 Consensus Guidelines, and does not exclude a diagnosis of FD. 4, 5 Epidemiology Dyspeptic symptoms are common in the general population, with frequencies ranging from 10% to 45%. 8, 26, 34, 36, 38, 50, 52 The frequency of dyspepsia is slightly higher in women than men and in smokers and NSAID users, and the influence of age varies across studies. Results of prevalence studies are strongly influenced by the criteria used to define dyspepsia, and several studies have either included patients with typical symptoms of GERD or not incorporated the presence of dyspepsia-type symptoms in many patients with GERD. When heartburn is excluded, the frequency of uninvestigated dyspepsia in the general population ranges from 5% to 15%. 26, 34, 36, 38, 50, 52 Long-term follow-up studies have suggested that symptoms improve or resolve in more than half of patients. 19, 53 The annual incidence of dyspepsia has been estimated to range from 1% to 6%. 19 Quality of life is significantly affected by dyspepsia, especially FD. 50 Although the majority of patients do not seek medical care, a significant proportion will eventually seek consultation, which results in substantial costs. 19, 26, 54, 57 Factors that influence healthcare seeking are symptom severity, fear of underlying serious disease, psychological distress, and lack of adequate psychosocial support. 56, 57 Pathophysiology Several pathophysiologic mechanisms have been suggested to underlie dyspeptic symptoms: delayed gastric emptying, impaired. Table 14.1 Frequency of delayed gastric emptying in studies of patients with functional dyspepsia. Investigators/year-end frequency, %. Asano 2017 94 11 Jian 1989 28 59 Clauser 1993 69 35 Moss 1997 344 30 Perry 1998 304 33 Sarnelli 2003 392 23 Scott 1993 75 28 Stang Helena 1996 343 34 Tally 1989 32 30 Tally 2001 551 24 Tally 2006 864 34 Van Heel 2017 560 23 Waldron 1991 50 42 Wagoner 1989 43 30 Gastric accommodation to a meal, hypersensitivity to gastric distension, low-grade mucosal inflammation, altered duodenal sensitivity to lipids or acid, abnormal intestinal motility, and CNS dysfunction. 3, 8 The Heterogeneity of FD seems to be confirmed by the contribution of one or more of these disturbances in subgroups of patients. Studies that have investigated the pathophysiologic mechanisms of FD predated the Rome IV guidelines and classification, so many defined FD according to the Rome I and II consensus definitions. Delayed gastric emptying. Several studies have investigated gastric emptying and its relationship to the pattern and severity of symptoms in patients with FD. The frequency of delayed gastric emptying ranges from 20% to 50%, Table 14.1.3, 8 in a meta-analysis of 17 studies involving 868 dyspeptic patients and 397 controls. A significant delay in solid gastric emptying was present in almost 40% of patients with FD.58. Most of the studies, however, were performed in small groups of patients. In the largest studies, gastric emptying of solids was delayed in about 30% of the patients with FD.3, 23, 59-61. In a large-scale study using breath testing to measure gastric emptying in Rome III defined subgroups, delayed emptying was found in only 23%, and there was no preferential association with PDS.61. Most studies failed to find a convincing relationship between delayed gastric emptying and the pattern of symptoms. Large-scale single-center studies from Europe showed that patients with delayed gastric emptying of solids are more likely to report postprandial fullness, nausea, and vomiting. 23, 59-61. Although two large multi-center studies in the USA found no or a weak association. 62, 63. Whether delayed gastric emptying causes symptoms or is an epiphenomenon is a matter of ongoing controversy. Impaired gastric accommodation to a meal. The motor functions of the proximal and distal stomach differ remarkably. Whereas the distal stomach regulates gastric emptying of solids by grinding and sieving the content until the particles are small enough to pass the pylorus, the proximal stomach serves mainly as a reservoir during and after ingestion of the meal. Accommodation of the stomach to a meal is a vagally mediated reflex relaxation of the proximal stomach and provides the meal with a reservoir, thereby enabling the stomach. Table 14.2. Evidence of impaired accommodation in studies of patients with functional dyspepsia as compared with healthy persons. Investigator/year and technique difference from healthy persons. Asano 2017. 94 Scintigraphic distribution. Impaired accommodation in 15%. Boextens 2001. 44 Gastric barostat. No difference. Breed Neward 2003. 151 SPECT imaging. Impaired accommodation in 43%. Caldarella 2003. 30 Gastric barostat. Impaired accommodation as a group. Castillo 2004. 35 SPECT imaging. No difference. Coffin 1994. 10 Gastric barostat. Impaired accommodation as a group. Gilja 1996. 20 U.S. Impaired accommodation as a group. Kim 2001. 33 SPECT imaging. Impaired accommodation as a group. Abnormal in 41%. Pisavo 2004. 40 Scintigraphic distribution. No difference as a group. Distal redistribution in up to 50%. Salet 1998. 12 Gastric barostat. Impaired accommodation as a group. TAC 1998. 40 Gastric barostat. Impaired accommodation as a group. Abnormal in 40%. Thumbs-Hearn 1999. 17 Gastric barostat. Impaired accommodation in 70%. Tronken 1994. 11 Scintigraphic distribution. Altered intragastric distribution as a group. Van Heel 2017. 560 barostat. Impaired accommodation in 37%. SPECT, single photon emission CT. To handle large intragastric volumes without a rise of intragastric pressure. 64 Studies using intragastric manometry have shown that ingestion of a meal is associated with a drop in intragastric pressure followed by a gradual recovery of the pressure during continued ingestion of nutrients, with increasing meal-induced satiation. 65 Studies using the gastric barostat, scintigraphy, US, single photon emission CT, or non-invasive surrogate markers, e.g., satiation drinking test, have all identified impaired accommodation in approximately 40% of patients with FD, Table 14.2.3, 20, 22, 61, 64A Barostat study of gastric accommodation in patients with Rome-3 defined subtypes of FD found impaired accommodation in 37% but showed no preferential association with PDS.61. Lack of accommodation of the proximal stomach during and after the ingestion of a meal may be accompanied by increased intragastric pressure and activation of mechanoreceptors in the gastric wall, thus inducing symptoms. Although a number of studies have found an association between impaired accommodation and early satiation and weight loss, others have failed to find such an association. 3, 20, 22, 61, 64. The mechanisms by which impaired accommodation can cause symptoms is still unclear. Meal ingestion in the absence of proper relaxation of the proximal stomach may be accompanied by activation of tension-sensitive mechanoreceptors in the proximal stomach. On the other hand, insufficient accommodation of the proximal stomach may force the meal into the distal stomach, thereby causing activation of tension-sensitive mechanoreceptors in a distended antrum. 64 Hypersensitivity to gastric distension. Visceral hypersensitivity, defined as abnormally enhanced perception of visceral stimuli, is considered one of the major pathophysiologic mechanisms in functional GI disorders. See Chapter 22. 65 Several studies have established that, as a group, patients with FD are hypersensitive to isobaric gastric distension. 3, 21, 61A study in patients with Rome-3 defined FD subgroups identified hypersensitivity in 37%, but there was no preferential association with any of the subtypes. 60 The level at which visceral hypersensitivity is generated is unclear, and there is evidence for involvement of tension-sensitive mechanoreceptors as well as alterations at the level of visceral afferent nerves or of the central nervous system. 66-69 Low-grade mucosal inflammation in the duodenum. Low-grade mucosal inflammation in the duodenum, which is evident from the presence of increased duodenal mucosal mast cell and eosinophil counts, has been identified in patients with FD as a group. 70-72 The investigation of immune dysfunction in FD was initially triggered by observations in patients with post-infection FD. 73 But it is now clear that increased eosinophil and mast cell numbers are present in a large subset of patients with FD and that these findings are most clearly associated with symptoms of early satiation. 70 The inflammatory cell infiltrate, eosinophils and mast cells, in the duodenum has been correlated with increased mucosal permeability and altered expression of tight junction proteins and with impaired activity and integrity of neurons in the submucous plexus. 71, 72 To what extent low-grade duodenal inflammation is associated with the changes in gastric sensorimotor function described earlier, or with increased sensitivity to duodenal luminal contents discussed later, remains to be evaluated. Altered duodenal sensitivity to lipids or acid in healthy persons and in patients with FD, perfusion of the duodenum with nutrient lipids, but not glucose, enhances the perception of gastric distension through a mechanism that requires lipid digestion and subsequent release of CCK. 74-76 Duodenal infusion of hydrochloric acid induces nausea in patients with FD but not in healthy subjects, suggesting duodenal hypersensitivity to acid. 77 Duodenal pH monitoring using a clipped pH electrode has revealed increased postprandial duodenal acid exposure in patients with FD compared with controls, and this difference has been attributed to impaired clearance of acid. 78 On the basis of these observations, increased duodenal sensitivity to lipids or acid has been proposed to contribute to the generation of symptoms in patients with FD, but research in this area is needed. Other mechanisms. One study of patients with FD reported a high frequency of rapid gastric emptying that was correlated with the intensity of postprandial symptoms. 79 But other studies have failed to support these findings. 23, 35, 61 Phasic fundic contractions induce transient increases in gastric wall tension that can be perceived in patients with FD. 67 One study reported lack of suppression of phasic contractility of the proximal stomach after a meal in a subset of patients with FD. 80 Abnormalities in the control of gastric myoelectrical activity, as measured by cutaneous electrogastrography, have been found in up to 2/3 of patients with FD. 81, 82 No correlation was found between the pattern of symptoms and the presence of electrogastrographic findings. Small bowel motor alterations, most commonly hypermotility with burst activity or clusters and an increased proportion of duodenal retrograde contractions, see Chapter 99, have been reported in patients with FD, but no clear correlation with symptoms has been found. 83 Pathogenic factors. The cause of symptoms in patients with FD has not been established, but evidence exists for genetic susceptibility, infective agents, and psychological factors. The relationship between potential pathogenic factors and putative pathophysiologic mechanisms has not been addressed in depth. Genetic predisposition population studies have suggested that genetic factors contribute to FD. The frequency of dyspepsia is increased in first-degree relatives of affected patients compared with the frequency in their spouses. 84 Polymorphisms of the G protein beta polypeptide 3 gene, GNB3, have been associated with the risk of FD85, but the specific polymorphism and an association with dyspepsia subgroups have been inconsistent among studies from different parts of the world. 86 Additional and larger confirmatory studies are needed. Infection. HP infection. Depending on the region and population studied, a variable proportion of patients with FD are infected with HP. 3.8 Although HP is associated with a number of organic causes of dyspepsia, there is only limited evidence to support a causal relationship between HP and FD. 87 No consistent differences in the pattern of symptoms or putative pathophysiologic mechanisms have been found between HP positive and HP negative subjects. 3.8 88 The best evidence in support of a role for HP in the pathogenesis of FD is the small but statistically significant beneficial effect of eradication therapy on symptoms in patients with FD. 87, 89 These considerations have led to the Kyoto Consensus, which defines HP-associated dyspepsia as dyspepsia in an HP-infected person with the absence of an alternative cause of dyspepsia on endoscopy and sustained control of symptoms after eradication of HP. 90 Determination of the size of this group, both in Western and non-Western clinical practices, and the long-term outcome require further studies. Post-infection functional dyspepsia. Post-infection FD was first proposed as a clinical entity on the basis of a large retrospective study from a tertiary referral center. 22 Compared with patients who had FD of unspecified onset, patients with a history suggestive of post-infection FD were more likely to report symptoms of early satiation, weight loss, nausea, and vomiting, and had a significantly higher frequency of impaired accommodation of the proximal stomach, which was attributed to dysfunction at the level of gastric nitrogen neurons. 22 The frequency of HP infection is not increased in post-infection FD, indicating that HP is not the causal infectious agent. Patients with post-infection FD have more prominent mucosal inflammation in the duodenum. 73 In a prospective cohort study, development of FD was increased five-fold 1 year after acute Salmonella gastroenteritis, compared with subjects who had not had gastroenteritis. 91 Additional studies are required to identify the underlying pathophysiology and risk factors and to assess the long-term prognosis. Psychosocial factors. A review of the literature reveals a clear association between psychosocial factors and FD. 3.8 92 The most common psychiatric comorbidities. Indiana patients with FD are anxiety, depressive or somatoform disorders, and a recent or remote history of physical or sexual abuse. Psychological distress has long been a recognized feature of healthcare-seeking behavior in patients with functional bowel disorders, including FD, see Chapter 22. Studies have confirmed an association between dyspeptic symptoms in the general population and psychosocial factors like somatization, anxiety, and stressful life events. This association argues against a mere healthcare-seeking effect. 27, 36, 92, 93 Symptom severity in patients seen at a tertiary care center is more strongly related to psychosocial factors, especially depression, abuse history, and somatization, than to abnormalities of gastric sensorimotor function. 94 Although these observations show a close interaction between different psychosocial variables and the presence and severity of symptoms of FD, they do not establish whether psychosocial factors and FD are separate manifestations of a common predisposition or whether psychosocial factors play a causal role in the pathophysiology of dyspeptic symptoms. Longitudinal studies support the idea of a common predisposition, as FD has been reported to both precede and follow the development of a mood disorder in population-based studies, and each component increases the risk for the other. 96 The presence of psychosocial comorbidities is also associated with greater symptom severity in patients with FD, and this association may be mediated in part by visceral hypersensitivity. 97 Acutely induced anxiety in healthy volunteers, however, is not associated with increased visceral sensitivity but with decreased gastric compliance and inhibition of meal-induced accommodation. 98 In patients with FD, a correlation between anxiety and gastric sensitivity was found in a subgroup of hypersensitive patients with FD, but not in the overall group of patients with FD. 97 A history of abuse was associated with visceral hypersensitivity in patients with FD. 99 Approach to uninvestigated dyspepsia. Taking into account the high prevalence of dyspepsia and the large number of subjects that present to a physician for their symptoms, the initial aim of managing patients is to decide which patients can be managed empirically and which patients should be referred for additional diagnostic evaluation. History and physical examination. A complete clinical history should be obtained and a physical examination performed in all patients with dyspepsia. The nature, frequency, and chronicity of the symptoms, as well as the relationship to ingestion of meals and the possible influence of specific dietary factors, should be assessed. The onset of symptoms acute with a gastroenteritis-like episode or more gradual is also of interest. The amount of weight loss, if present, should be determined, as should other alarm symptoms like anemia, blood loss, and dysphagia. Distinguishing the EPS from PDS symptom subgroup according to the Rome-4 classification may influence the choice of treatment. See later. 5 In patients with long-standing symptoms, the reason for seeking healthcare at this time should be elicited, so that specific fears and concerns can be addressed. Further assessment of symptoms or signs of a systemic disorder, e.g., diabetes mellitus, cardiac disease, thyroid disease, and of the patient's family and personal history will indicate whether the patient is at risk for a particular organic disease that may present as dyspepsia. Physical findings such as an abdominal mass, organomegaly, ascites, or a positive fecal occult blood test result warrant further evaluation. Specific attention should be given to elicit a history of heartburn, and a word picture questionnaire may help the patient recognize the typical symptom pattern. 45 Burning pain confined to the epigastrium is a cardinal symptom of dyspepsia and is not considered heartburn unless it radiates retrosternally. The presence of frequent and typical reflux symptoms should lead to a provisional diagnosis of GERD rather than dyspepsia, and the patient should be treated initially for GERD. See Chapter 46. Overlap of GERD with dyspepsia is probably frequent and should to be considered if the patient's symptoms do not respond to appropriate management of GERD. The possible presence of overlapping IBS should also be assessed, and symptoms that improve with bowel movements or are associated with changes in stool frequency or consistency should lead to a presumptive diagnosis of IBS. A structured questionnaire with pictograms that incorporates the heartburn word picture may help identify the nature of symptoms as distinct from nausea, GERD, and IBS. 100 The use of prescription and non-prescription medications should be reviewed, and medications commonly associated with dyspepsia, especially NSAIDs, should be discontinued if possible. In patients in whom NSAIDs cannot be discontinued, a trial of a PPI can be considered, although many guidelines recommend endoscopic evaluation first to exclude peptic ulcer. Laboratory testing. The cost-effectiveness of routine laboratory testing, especially in younger patients with uncomplicated dyspepsia, has not been established. Nevertheless, most clinicians will consider routine tests, CBC, serum electrolytes, serum calcium, liver biochemical tests, and thyroid function tests, after the age of 45 to 55. Other studies, such as a serum amylase level, antibodies for celiac disease, stool testing for ova and parasites or Giardia antigen, and a pregnancy test, may be considered in selected cases. 3, 5, 8, 10 Initial management strategies. In many cases, the patient's history and physical examination will allow dyspepsia to be distinguished from symptoms suggestive of esophageal, pancreatic, or biliary disease, but both primary care physicians and gastroenterologists should be aware that the Patient's history and physical findings, and even the presence of alarm symptoms, are unreliable in distinguishing functional from organic causes of dyspepsia. 5, 8, 9, 11, 10102. Therefore, most guidelines and recommendations advocate prompt endoscopy when risk factors for dyspepsia, e.g., NSAID use, age above 40 to 55, alarm symptoms, are present. 103-105. The optimal management strategy for the majority of patients who do not have a risk factor for an organic cause of dyspepsia remains a matter of debate and controversy, and several approaches have been proposed. Available options include 1. Prompt diagnostic endoscopy, followed by targeted medical therapy, 2. Non-invasive testing for HP infection, followed by treatment based on the result, test and treat strategy, and 3. Empirical anti-secretory therapy. In the two latter strategies, endoscopy is performed in patients who do not respond to treatment or experience recurrent symptoms. In theory, empirical prokinetic therapy could also be considered as an initial option but is generally not recommended because of the lack of widely available prokinetic drugs with established efficacy. 104. Prompt endoscopy and directed treatment diagnostic EGD allows direct detection of organic causes of dyspepsia, such as peptic ulcer, erosive esophagitis, or malignancy. Endoscopy before any therapy has been instituted is still considered the gold standard for the diagnosis of UGI. Table 14.32 Meta-analyses of initial management strategies in patients with uninvestigated dyspepsia. Investigator/year relative risk, 95% CI, prompt endoscopy versus empirical acid suppression. Bitzer 1994 0.99, 0.61 to 1.63, Delaney 2001 0.93, 0.78 to 1.10, Duggan 1999 0.86, 0.63 to 1.18, Lewin 1999 0.75, 0.54 to 1.05, overall 0.89, 0.77 to 1.02, an HP test and treat strategy versus endoscopy. Ahrens 2003 1.05, 0.90 to 1.21, Duggan 1999 1.38, 1.03 to 1.84, Haney 1999 0.82, 0.60 to 1.11, Lassen 2001 0.84, 0.59 to 1.19, McCall 2002 0.78, 0.51 to 1.19, overall 0.98, 0.81 to 1.18, neither analysis demonstrated a difference between strategies. CI, confidence interval. Disorders. 106. The procedure may also have a reassuring effect on patients and physicians. 107-109. Gastric mucosal biopsies facilitate diagnosis of HP infection, which should be followed by eradication therapy if the results are positive. Endoscopy has been claimed to detect early gastric cancer at a curable stage, but evidence for this claim is weak at best. 110-112. Endoscopy is also expensive and invasive and may not have such a major impact on treatment after all. Patients found to have peptic ulcer or erosive esophagitis will receive anti-secretory therapy, and in those with a negative result on EGD, FD, and non-erosive GERD are likely diagnoses, both of which can be treated empirically with anti-secretory therapy. Still, it has been argued that initial empirical anti-secretory therapy will only delay endoscopy, because both FD and GERD are likely to recur after discontinuation of empirical therapy, at which time the patient will be referred for endoscopy. A number of randomized controlled trials have compared prompt endoscopy with empirical non-invasive management strategies. A meta-analysis of 5 trials that compared initial endoscopy with a test and treat strategy concluded that initial endoscopy may be associated with a small reduction in the risk of recurrent dyspeptic symptoms, but that this gain was not cost-effective. Table 14.3.113. Most relevant studies found that the direct and indirect costs associated with prompt endoscopy are higher than those associated with empirical therapy and are not completely offset by reduced medication use or subsequent physician visits. 104-116. Available data, therefore, do not support early endoscopy as a cost-effective initial management strategy for all patients with uncomplicated dyspepsia. Nevertheless, most relevant practice guidelines advocate initial endoscopy in all patients above a certain age threshold, usually 45 to 55 years old, to detect potentially curable UGI malignancy. 103-105 The rationale for this approach is that the vast majority of gastric malignancies occur in persons over 45 years of age and that the rate of cancer detection rises in persons with dyspepsia who are 45 years of age or older. 110-112 Most patients with newly diagnosed gastric cancer are already incurable at the time of diagnosis, however, and many will have an alarm feature that would have warranted immediate endoscopy. 112 In patients younger than age 45 who have a family history of gastric cancer, emigrated from a country with a high rate of gastric cancer, or have undergone partial gastrectomy, early endoscopy is also recommended. Test and treat for HP infection. HP is causally associated with the majority of peptic ulcers and is the most important risk factor for gastric cancer. See chapters 52 to 54. 117 Because of the involvement of HP in PUD, several consensus panels and guidelines have advocated non-invasive testing for HP in young patients, 45 to 60 years of age, with uncomplicated dyspepsia. 8. 103-105 Persons with a positive test result should receive eradication therapy, a PPI and 2 antibiotics, such as amoxicillin and clarithromycin, depending on local resistance patterns, taken for 14 days, whereas patients with a negative test result should be treated empirically, usually with a PPI. The benefits of this test and treat strategy are the cure of PUD or prevention of future peptic ulcers and symptom resolution, 7% above the rate with placebo, in a small subset of patients with dyspepsia who are infected with HP. 89, 90, 104, 113, 114, 118 Eradication of HP eliminates chronic gastritis and may thereby contribute to a reduction in the risk of HP-associated gastric cancer. 119 On the other hand, in Western countries, the prevalence of HP infection in patients with uninvestigated dyspepsia is declining rapidly, and infection rates are especially low, 10% to 30%, in persons younger than 30 years of age. Widespread use of antibiotics has the disadvantage of inducing resistance and occasionally causing drug allergies. Whether eradication of HP causes or worsens GERD has long been debated. 120 But a randomized controlled trial in HP-positive patients with GERD failed to demonstrate any worsening of GERD. 121 Furthermore, the accuracy of non-invasive testing depends on both the prevalence of HP in the population and the sensitivity and specificity of the test. Serologic tests for HP are the least expensive but also the least accurate. If the prevalence of HP in a population is less than 60%, the fecal antigen test and urea breath test for HP are preferred, because their higher accuracy reduces inappropriate treatment for patients without HP infection. See Chapter 52. 122 Randomized placebo-controlled trials have shown only a modest reduction in symptoms of dyspepsia after a test and treat approach in primary care. 123-125 A meta-analysis of studies comparing a test and treat strategy with empirical anti-secretory therapy in patients with dyspepsia found little difference in the frequency of symptom resolution or costs between the two strategies. 126 Although earlier models that assumed higher prevalence rates of HP infection suggested a greater benefit to a test and treat strategy. 127-129 Economic models have suggested that the test and treat approach may be equally or less cost-effective than empirical anti-secretory therapy. 131 The test and treat strategy as an initial approach to uninvestigated dyspepsia is most likely to be beneficial in areas where the HP infection rate is high. Empirical anti-secretory drug therapy. Initial empirical anti-secretory therapy is widely used in primary care for patients with uninvestigated dyspepsia. The approach is attractive because it controls symptoms and heals lesions in most patients with underlying GERD or PUD and may be beneficial for up to one-third of patients with FD. 132, 133 PPIs provide superior symptom relief compared with H2RAS, and the response usually occurs within 2 weeks of therapy. 103-105 Disadvantages of empirical PPI therapy are rapid symptomatic relapse after therapy is discontinued and the potential for rebound gastric hypersecretion. 134 So many patients require long-term PPI therapy. As noted earlier, a meta-analysis of studies that compared a test and treat approach with empirical anti-secretory therapy in patients with dyspepsia found little difference in symptom resolution or costs between the two strategies. 126. However, economic analyses indicate that empirical anti-secretory therapy may be equally or more cost-effective. 130. 131 Recommendations. The optimal cost-effective approach to the initial management of uncomplicated dyspepsia remains unclear. Clinical decision-making should take into account specific aspects of a patient's case and weigh several risk-benefit factors. In a young dyspeptic patient, age 50 to 60, without alarm features, initial endoscopy cannot be recommended because the yield is low and the test is unlikely to lead to improved outcomes. This position can be reconsidered if the patient is worried about an underlying disease, has a family history of cancer, or has emigrated from an area with a high incidence of gastric or esophageal cancer. In a population with a high prevalence, 20%, of HP infection, the test and treat approach remains attractive because patients with PUD will be cured. The tests of choice are the urea breath test or the fecal antigen test. HP-positive patients should be given a course of HP eradication therapy, see Chapter 52. In those who are negative for HP, a PPI can be prescribed for 1 to 2 months. In populations in which the prevalence of HP infection is low, empirical anti-secretory therapy, a PPI for 1 to 2 months, appears to be the preferred option. Patients who fail to respond to these initial approaches, and possibly those in whom symptoms recur after cessation of anti-secretory therapy, should undergo endoscopy, although the yield is likely to be low. In patients older than age 50 to 60 without alarm features, most guidelines recommend initial diagnostic endoscopy, although the benefit in terms of detection of early-stage malignancies remains unproved. In these cases, management will depend on endoscopic findings and detection of HP, but PPI therapy is likely to be prescribed to most patients. Additional investigations may be pursued in patients with progressive or refractory symptoms that do not respond to initial management approaches. Testing for celiac disease and Giardia infection is useful for patients with refractory symptoms, especially when accompanied by weight loss. In patients with severe pain or weight loss, US or CT can rule out pancreaticobiliary disease and screen for stenosis of large abdominal arteries. In case of severe postprandial fullness, and especially in case of refractory nausea and vomiting, a gastric emptying study using scintigraphy or a breath test can be considered. When gastric emptying is severely delayed, a small bowel X-ray can rule out mechanical obstruction as a contributing factor. In cases of refractory intermittent epigastric pain or burning, esophageal pH with impedance monitoring is useful for diagnosing atypical manifestations of GERD not responding sufficiently to empirical anti-secretory drug therapy. Psychological or psychiatric assessment is recommended for patients with long-standing refractory or debilitating symptoms. Electrogastrography, barostat studies, or simple nutrient challenge tests have been used in pathophysiologic studies but have no established role in the clinical management of dyspeptic patients. Treatment of functional dyspepsia. General measures reassurance and education is of primary importance in patients with FD. Despite normal findings at endoscopy, the patient should be given a confident diagnosis. In IBS, a positive physician-patient interaction has been shown to reduce healthcare seeking behavior, and this approach is probably applicable to patients with FD as well. 135 Lifestyle and dietary measures are usually prescribed to patients with FD, but the impact of dietary interventions has not been studied systematically. 14 Advising patients to eat more frequent, smaller meals seems logical. Because the presence of lipids in the duodenum enhances gastric sensitivity, avoiding meals with a high fat content may be advisable. 75, 76 Similarly, physicians tend to discourage consumption of spicy foods containing capsaicin and other irritants. 15 Coffee may aggravate symptoms in some cases. 136 And, if implicated, should be avoided. Cessation of smoking and consumption of alcohol is thought to be helpful, but without convincing evidence of efficacy. 127 Avoidance of aspirin and other NSAIDs is commonly recommended and seems sensible, although not of established value. 16 If the patient has an apparent coexisting anxiety disorder or depression, appropriate treatment should be prescribed. Pharmacologic treatment for many, but not all, patients, pharmacotherapy will be considered. The efficacy of pharmacologic treatments for FD is limited, however. Acid suppressive drugs in patients with GERD, a trial of anti-secretory therapy often has both therapeutic and diagnostic value. Based on meta-analyses of therapeutic outcomes in FD, the efficacy of antacids, sucralfate, and misoprostol has not been demonstrated. 137 A meta-analysis of 12 randomized placebo-controlled trials that evaluated the efficacy of H2RAS in patients with FD reported a significant benefit over placebo, with a relative risk reduction of 23% and a number needed to treat of 7.137 H2RAS, therefore, appear to be efficacious in FD. But many of these trials probably included patients with GERD under a broad interpretation of FD, thereby accounting for much of the benefit. A meta-analysis of 15 placebo-controlled, randomized trials of PPIs for FD also confirmed that this class of agents is superior to placebo, with the number needed to treat of 10, Table 14.4, 0.104, 138. The relative risk reduction was lower, 13%, than for H2RAS, probably reflecting more stringent entry criteria and better exclusion of patients with GERD. No difference in efficacy was found between standard and low-dose PPI therapy, and double-dose PPI therapy was not superior to single-dose PPI therapy. 104, 138. The patient's HP status did not affect the response to PPI therapy. Subgrouping of FD using previous Rome classifications showed a trend for PPI therapy to be most effective in the group with overlapping reflux, less effective in the group with epigastric pain, probably corresponding to EPS, and lacking a statistically significant effect in the group with dysmotility, probably corresponding to PDS. 138 Prospective studies of PPI therapy for FD in patients subgrouped according to the Rome 4 classification are lacking. Eradication of HP infection. A meta-analysis has reported a 9% reduction in the frequency of dyspepsia after HP eradication compared with placebo at 12 months of follow-up, with the number needed to treat of 12.5, Table 14.5, 0.104. Arguments against eradication therapy are the low number of responders and the delayed occurrence of demonstrable symptomatic benefit. It has been argued, however, that HP eradication can induce sustained remission in dyspepsia, albeit in a minority of patients. 139 These patients are referred to as having HP-associated dyspepsia according to the Kyoto Global Consensus Conference Report. 90 Other arguments in favor of the use of eradication therapy are protection against PUD, presumed protection against gastric cancer, and the short-term nature and relatively low cost of treatment. Prokinetic agents. Gastric prokinetic agents are a heterogeneous class of compounds that act through different types of receptors to exert a stimulatory effect on gastric motility. The efficacy of available prokinetic agents in patients with FD has been controversial. 104, 137, 141-42 A meta-analysis has suggested that therapy with a prokinetic agent is superior to placebo in patients with FD, with the number needed to treat of 7. But this effect was largely driven by cisapride, and removal of data for cisapride increased the number needed to treat to 12, Table 14.6, 142 Metoclopramide and domperidone are dopamine receptor agonists with a stimulatory effect on UGI motility. Unlike metoclopramide, which may cause serious neurologic adverse effects, domperidone does not cross the blood-brain barrier but has been associated with QT interval prolongation on electrocardiography and may precipitate cardiac arrhythmias. Moreover, placebo-controlled studies of domperidone in patients with FD are lacking. 104, 142 Cisapride facilitates the release of acetylcholine in the myenteric plexus via 5-hydroxytryptamine 4, 5-HT4, receptor agonism and accelerates gastric emptying. The available trials with these drugs, however, were of poor quality, concerns were raised about publication bias, and cisapride was withdrawn from the market in the USA for safety concerns. 141, 142 other agents with evidence of efficacy were tegaserod and icosiamide, see later. 142-144 tegaserod showed only a small benefit over placebo. 143 and is currently not available in most countries because of concerns about potentially associated cardiovascular risk. 145 Unfortunately, studies of other types of prokinetic agents have generally been unsuccessful in providing convincing evidence of Table 14.5 meta-analysis of randomized, controlled trials of HP eradication in patients with functional dyspepsia. Treatment control risk ratio relative risk investigator/year events total relative risk 95% CI 95% CI Ang 2006 49 71 45 59 0.90 0.73 1.12 Bloom OCAY 1998 119 164 130 164 0.92 0.81 1.03 Frulich 2001 30 174 34 70 0.86 0.60 1.24 Gilbert 2004 13 34 816 0.76 0.40 1.46 Gonzalez Caro 2004 22 47 31 46 0.69 0.48 1.00 Gui 2009 31 41 38 41 0.82 0.67 0.991 HSU 2001 34 81 36 80 0.93 0.66 1.33 Coeltz 2003 67 89 73 92 0.95 0.81 1.111 Koskin-Pato 2001 61 77 63 74 0.93 0.80 1.081 Land 2011 86 98 94 97 0.91 0.83 0.981 Metfurthiner 2003 338 534 177 266 0.95 0.85 1.061 Martinek 2005 5 2012 20 0.42 0.18 0.961 Mezzoleni 2006 39 46 40 43 0.91 0.79 1.061 Mezzoleni 2011 166 201 175 203 0.96 0.88 1.041 McCall 1998 121 154 143 154 0.85 0.77 0.931 Maway 2033 48 28 37 0.91 0.70 1.18 Ruiz 2005 46 79 64 79 0.72 0.58 0.89 Saudi 2013 164 259 188 260 0.88 0.78 0.99 Tally, Orchid 1999 101 133 111 142 0.97 0.85 1.11 0.50 0.71 1.52 Tally, USA 1999 122 150 120 143 0.97 0.87 1.08 Favors Van Zanten 2003 45 75 55 82 0.89 0.70 1.14 Treatment Control Varens 2001 74 129 86 124 0.83 0.68 1.00 Total 2604 2292 0.91 0.88 0.94 Total Events 1767 1751 events. Signify the number of patients with symptomatic improvement. Total signifies the total number of patients treated. From Moe Yeti PM, Lacey B., Andrews CN, ETAL AC and CAG Clinical Guideline, Management of Dyspepsia. AMJ Gastrointestinal 2017, 112:988-1013. CI, Confidence Interval. Symptomatic relief in patients with FD.146 on the basis of a systematic analysis. The efficacy of prokinetic agents is not thought to be driven by their stimulatory effect on gastric emptying, but rather by effects on accommodation and visceral hypersensitivity. 141, 146. Although some prokinetic agents impair gastric accommodation and increase gastric sensitivity, others may enhance gastric accommodation, see later. 141. Agents that enhance gastric accommodation. Impaired gastric accommodation is the most commonly found motor abnormality in FD, see earlier. In a mechanistic proof-of-concept study, the anxiolytic 5-HT1A agonist buspirone improved both symptoms of early satiation and gastric accommodation, without effects on anxiety. To explain the symptomatic benefit. 147. A multi-center 4-week study of tandospirone, another 5-HT1A agonist, also demonstrated alleviation of epigastric pain and discomfort independent of changes in anxiety and depression levels. 148. The first-in-class agent acosiamide is both a presynaptic muscarinic autoreceptor inhibitor and a cholinesterase inhibitor and enhances both gastric emptying and accommodation. 149. A single 4-week phase 3 study was conducted in Japan and showed favorable effects of acosiamide on early satiation, postprandial fullness, and upper abdominal bloating in patients with PDS. 144. The drug was well tolerated, and the findings were confirmed in a 1-year open-label study in Europe. 150. Acosiamide is available only in Japan and India. Table 14.6. Meta-analysis of randomized, controlled trials of selected prokinetic agents in patients with functional dyspepsia. Prokinetic placebo risk ratio. Relative risk. Investigator/year events. Total relative risk, 95% CI, 95% CI. Cisapride vs placebo. AJ Quarane 1995 2247 0.49 0.36 0.67 Champion 1997 4326 0.80 0.59 1.08 De Groot 1997 2635 0.73 0.51 1.05 De Nut 1989 611 0.48 0.24 0.98 Francois 1987 817 14 17 0.57 0.33 0.99 Hansen 1998 101 109 99 110 1.03 0.95 1.12 Holtman 2002 51 52 1.01 0.88 1.17 Kello 1995 26 25 1.07 0.86 1.34 Roche 1987 27 45 0.60 0.44 0.81 Teixeira 2009 11 0.60 0.33 1.09 Wang 1995 137 414 145 169 0.39 0.33 0.45 Yeo 1997 46 52 47 52 0.98 0.86 1.12 Subtotal 969 678 0.71 0.54 0.93 Total events 502 557 Acosiamide vs placebo. Kusunaki 2012 15 21 18 21 0.83 0.60 1.15 Matsueda 2010 to 187 216 94 107 0.99 0.90 1.08 Matsueda 2010 to 290 346 99 116 0.98 0.90 1.07 Matsuoda 2012 383 452 405 445 0.93 0.89 0.98 TAC 2011 87 193 53 96 0.82 0.64 1.04 Tally 2008 195 312 71 104 0.92 0.78 1.07 subtotal 1540 889 0.94 0.91 0.98 total events 1157 740 Ida Pride vs placebo Holtman 2006 174 406 86 142 0.71 0.59 0.84 Ma 2012 53 119 79 120 0.68 0.53 0.86 Shen 2014 14 40 22 40 0.64 0.38 1.06 Tally 2008 to 124 264 226 260 0.54 0.47 0.62 Tally 2008 to 288 315 309 830 0.98 0.93 1.02 Wang 2014 316 414 0.66 0.18 2.44 subtotal 1160 906 0.70 0.47 1.03 total events 656 726 Tegaserod 6 mg bid vs placebo Vakil 2008 to 1 423 685 452 675 0.92 0.85 1.00 Vakil 2008 to 2 356 652 420 655 0.85 0.78 0.93 subtotal 1337 1330 0.89 0.82 0.96 total events 779 872 Mosa Pride vs placebo Hollerbach 2002 171 425 57 141 1.00 0.79 1.25 Lin 2009 21 30 26 30 0.81 0.61 1.06 0.20 0.5125 subtotal 455 171 0.91 0.73 1.13 favors Prokinetic placebo total events 192 83 ABT 229 vs placebo Tally 2253 488 47 121 1.33 1.05 1.70 subtotal 488 121 1.33 1.05 1.70 total events 253 47 total 5949 4095 0.81 0.74 0.89 total events 3539 3025 events signify the number of patients with symptomatic improvement. Total signifies the total number of patients treated. CI, confidence interval. From Moe Yeti PM, Lacey B., Andrews CN, ETAL AC and CAG Clinical Guideline, Management of Dyspepsia. AMJ Gastrointestinal 2017, 112:988-1013. Centrally acting neuromodulators. Psychotropic agents like antidepressants, anxiolytics, and antipsychotics are commonly used for the treatment of functional GI disorders that do not respond to initial conventional approaches. The rationale for their use is their potential to alter pain processing pathways in the brain and, based on this concept, they are now referred to as centrally acting neuromodulators. See chapters 12 and 22. 151. A meta-analysis has confirmed that centrally acting neuromodulators may be effective for treating FD, but convincing evidence is available only for atypical antipsychotics and tricyclic antidepressants. Trials of other agents are limited in size and numbers. 151, 152 in a multi-center trial in which patients with FD were randomized to treatment with placebo, amitriptyline, or escitalopram for 8 weeks. Only amitriptyline resulted in symptomatic improvement, which was confined to the subgroup characterized by epigastric pain, EPS-like subgroup. 153 Antidepressant therapy did not significantly alter the gastric emptying rate or nutrient volume tolerance, but amitriptyline increased gastric accommodation as assessed by single photon emission computed tomography imaging, c. Earlier, 154 treatment with amitriptyline and escitalopram did not significantly improve anxiety, depression, or somatization scores, but sleep was improved modestly by amitriptyline. 155. A large controlled trial with the selective serotonin and norepinephrine reuptake inhibitor venlafaxine in patients with FD failed to show any symptomatic benefit, and tolerance was poor. 156. Mirtazapine, an antidepressant with activity on diverse neurotransmitter receptors, was efficacious in non-depressed and non-anxious patients with FD and major weight loss. 156, 157. In addition to increased body weight, mirtazapine improved overall symptoms, early satiation, nausea, and nutrient volume tolerance. Other pharmacotherapeutic approaches on the basis of a meta-analysis of 4 trials, bismuth salts seemed efficacious, but this analysis had marginal statistical significance. 137. Simethicone was superior to placebo in one controlled trial. 158. Peppermint oil has also been evaluated in the treatment of FD. In a controlled trial, capsules of peppermint and caraway oil were superior to placebo in alleviating symptoms of both EPS and PDS, with good tolerance. 159. The mode of action remains to be established, but previous mechanistic studies showed that peppermint oil relaxes the proximal stomach. 160. In a study from Hong Kong, rifaximin, 400 mg 3 times daily for 2 weeks, was well tolerated and superior to placebo in providing adequate relief of belching and postprandial fullness and bloating. 161. This result requires confirmation before use of non-absorbable antibiotics can be recommended for the treatment of FD. Various studies have reported improvement in symptoms during treatment with mixed herbal preparations, Japanese Kampo medicine, Chinese herbals, or artichoke leaf extract. 162-167. The basis for the improvement remains to be determined. One study reported that long-term administration of red pepper was more effective than placebo in decreasing the intensity of dyspeptic symptoms in patients with FD. 168. Probiotic-containing products have become popular as self-management or prescribed treatment for bowel symptoms. Upper abdominal symptoms including PDS have been less well studied. Limited data suggest potential efficacy, but more studies are needed. 169-170. Psychological interventions. Although patients with FD have a higher prevalence of psychosocial comorbidities, the role of psychosocial factors in the generation of symptoms remains unclear. In part because of these comorbidities, psychological interventions such as group support with relaxation training, cognitive behavioral therapy, psychotherapy, and hypnotherapy have been used in patients with FD. A systematic review of clinical trials of psychological interventions for FD found that all trials claimed benefit from psychological interventions, with effects persisting for over 1 year, but all studies were limited by inadequate statistical analysis. 171. The authors concluded that evidence to confirm the efficacy of psychological interventions in FD is insufficient. Recommendations in patients with FD with mild or intermittent symptoms, reassurance, education, and some dietary changes may be sufficient. Drug therapy can be considered in patients with more severe symptoms or those who do not respond to reassurance and lifestyle changes. Testing for HP infection is recommended, and, if positive, eradication therapy can be prescribed. An immediate impact on symptoms is unlikely, however, and any potential benefit is observed mainly over a longer period of follow-up. Fig 14.3. PPIs and, if available, prokinetic agents may also be used in initial pharmacotherapy. The symptom pattern may help determine the most appropriate initial choice of treatment, and a change in drug class is advisable in case the therapeutic response is insufficient. A22, preferably, 4-week trial of PPI therapy should be given to all patients with coexisting heartburn and to those with EPS. In case of symptomatic relief, treatment should be interrupted and intermittent or chronic therapy with a PPI, or H2RA, tried for patients with repeated relapses. In those with PDS, a motility-modifying drug with an attractive safety profile, e.g., acoziamide, where available, can be considered. Metoclopramide and cisapride should not be used because of the risk of serious adverse events, and clinicians should be aware that domperidone has also been associated with QT prolongation. Although in theory combinations of PPIs and prokinetic agents may have additive symptomatic effects, single drug therapy is preferable. In patients with bothersome symptoms of EPS that persist despite initial treatment, a trial of a low-dose tricyclic antidepressant may be considered, even in the absence of apparent anxiety or depression. Higher doses can be considered in patients with significant anxiety or depression. Selective serotonin and norepinephrine reuptake inhibitors should be avoided. In patients with bothersome symptoms of PDS, treatment with a 5-HT1A agonist can be used for refractory early satiation. In patients with persisting symptoms, the gastric emptying time can be measured. In cases with severely delayed gastric emptying, the patient can be considered to have idiopathic gastroparesis, and strong prokinetic agents like erythromycin or prucalopride can be considered. See Chapter 50. A trial of simethicone, peppermint oil, or a medically prescribed herbal preparation with apparent benefit in controlled trials may also be considered in refractory patients. In case of debilitating epigastric pain, symptomatic analgesics, even possibly opioids, can be considered after appropriate exclusion of organic disease. Referral to a psychiatrist or psychotherapist can be considered in patients with obvious coexisting psychiatric disease, a history of abuse, or a debilitating impact of severe symptoms on daily life activities. Motivated patients may benefit from psychological approaches such as psychotherapy, hypnotherapy, cognitive behavioral therapy, or relaxation therapy. Full references for this chapter can be found on vexpertconsult.com. 190 Part 3 Symptoms, Signs, and Biopsychosocial Issues. Fig 14.3 Algorithm for the Management of Patients with Dyspepsia. Patients younger than age 45 to 55 who do not have alarm features may be treated empirically, whereas all others should be evaluated initially by EGD. 5-HT, 5-hydroxytryptamine, TCA, tricyclic antidepressant. Asterisk not available in the USA.